Yes,
So, well, welcome to the Montreal Heart Institute for the second case of this afternoon. First off, I'd like to thank the MedStream 360 team for this great opportunity to showcase some of the cases that we do in our lab. Also, I'd like to thank the team here. There's Dr. Robert Abram next to me. There's Theo, our fellow from Greece, Bianca, the scrub nurse. There's Didier, who's helping us as well. And there's outside the room, there's Jennifer, there's Cosmina, and Ghislain also helping us at the console. So with no further ado, I'll hand over the mic to Dr. Abram to discuss the case that we're going to talk about and perform this afternoon.
Thank you very much for the introduction, Hung. Is it possible that I see my slides?
Do you see our slides?
Okay, yes, great. So our case is titled Challenges Associated with Instant Restenosis. Next slide. We present here a 65-year-old gentleman who has a very interesting coronary artery disease. He presented for primary PCI to the proximal RCA with a bare metal stent. It was a driver stent, 3.5 by 12 millimeters. And he also had a bare metal stent in the posterior descending artery. That was in 2009. He subsequently presented with stable angina, and he was stented on the left anterior descending artery. After that, in 2022, he had a rotablator assisted PCI to the circumflex for unstable angina, and he had another distal RCA to proximal PDA rotablator assisted PCI of the RCA for unstable angina in May 2022. At that time, there was mild to moderate ISR instant restenosis in the proximal BMS stent in the right coronary artery. The patient was subsequently hospitalized for angina in November 2022. At that time, he was discharged on medical therapy because the nuclear scan showed no ischemia with a normal ejection fraction. Otherwise, the patient is known for hypertension, cholesterol, and he's an active smoker. So he presents to the hospital again with a diagnosis of unstable angina. He has increasing chest pain for the past 4 weeks, negative troponins, and unremarkable ECGs. We have repeated the coronary angiogram yesterday. Next slide. The coronary angiogram has shown no changes on the left coronary artery disease. So the stent we put in
can you show us, Jennifer, show us while Robert is talking? Show us the angiogram from yesterday.
So the left coronary artery was unremarkable. It was unchanged from 2022. However, there was progression of disease in the prox and mid right coronary artery segment with moderate to severe instant restenosis and also a severe lesion distal to the stent that looked long and calcified, greater than 20 millimeters.
Montre la droite, s'il te plaît, Jennifer.
So you can see here the left coronary artery system. The results are virtually unchanged from 5 months ago. And you can see here the long calcified lesion that also touches the bare metal stent that was put in 2009 in the proximal RCA. You can also see to the right side, the angiogram as it was, I believe, 7 months ago. So you can see the progression. Because the patient came for unstable symptoms, our decision was to assess the ischemic components of this lesion. And we did perform IFR, which was positive at 0.88 with no drift. And our plan today is to address this lesion and the ISR and also the mid RCA segment.
So can you show the RCA images from today? So as Robert mentioned, initially okay, can you let it run? The second one, not the first one, from today? Okay, so just to be sure that we're tackling a lesion that is physiologically significant, as Robert mentioned, non-hyperemic assessment was performed. And when we performed this, we realized that it was significant from a physiological perspective. But as this is an ISR case, obviously there's really no ISR assessment and PCI that should be planned without imaging. But before moving on, we'll show the rest of the slides. Go back to the slides. So you have the angiogram now. So this
Back
is
to
a
the slide.
physiologically significant
PowerPoint.
lesion. And we'll go back to the slide presentation.
Great. So today, when we approached this case, we had a couple elements that we wanted to discuss. First, for vascular access. In this case, because it's a long and calcified lesion, we might need calcium modification therapy, such as rod ablation or orbital atherectomy. And we might need to go with bigger size burrs, since the previous stent was a 3.5 millimeter stent. Therefore, we debated the vascular access, radial versus femoral, and also 6 French versus 7 French. In this gentleman, the radial pulse was excellent, and we used a 7-in-6 French sheet to actually get the radial access and also get all the benefits of the 7 French. We also discussed the guiding catheter. We had damping on the pressure as we intubated the ostium yesterday. Therefore, we didn't want to be too aggressive with the guide, and we favor a guide extension if we need more support. So we pick a JR4 guide. And the choice for lesion modification, all choices are on the table. We could use non-compliant or PN high pressure balloons, atherectomy or intravascular lithotripsy or laser, according to the imaging and how the lesion performs. So we'll show you that. And like Dr. Lee mentioned, in any case of in-stent restenosis, imaging is of the essence. We want to understand the mechanism of the ISR. Although in this case, because it's a bare metal stent that's more than 13 years old, we suspect intimal hyperplasia with potential new atherosclerosis.
Maybe move on to the next slides. So points of discussion: optimal management for patient in a scenario of in-stent restenosis. How do we approach? As you could see by angiographic assessment, that there were calcification, whether they're moderately or heavily calcified. We could see in 2 different angles, orthogonal views, that we could see some calcium lining the vessel in and around the stented area. So that you could at least angiographically say that we have to tackle a heavily calcified lesion. Obviously, as mentioned, intravascular intracoronary imaging will be done. Here, the choice of antiplatelet, we were in a case of unstable angina. The patient had issues with bradycardia initially, so the choice was to keep him on clopidogrel and aspirin and heparin. Robert, I think, yeah, we can move on to the next couple of slides.
There's been a lot of publications and state-of-the-art reviews in the last year on in-stent restenosis. Here is a state-of-the-art review that was published in JACC in 2022. And I wanted to showcase some of the risk factors that this patient has for ISR. So for ISR, there's always 3 buckets of risk factors. We're talking about anatomical factors relating to the procedure, clinical factors, and also stent-related factors. So in this case, the patient has a calcified and lung lesion, which represent anatomical factors for in-stent restenosis. For clinical factors, diabetes remains the #1 risk factor clinically that predispose patients to in-stent restenosis, and also older age and previous MI and multiple stents. Now, there's also stent-related factors. This gentleman has one of the first generation's bare metal stents that has thicker struts, which has been associated with in-stent restenosis. And he also had a bare metal stent, which has about 3 to 5 times the failure rate at long term compared to drug-eluting stents. So because of those factors, it leads to intimal hyperplasia, which is like scar tissue inside the stent, and also new atherosclerosis in some of those patients, depending on the coronary artery disease substrate. Next slide. So there's also another article that was published in Eurointervention 2022 for the management of in-stent restenosis. And you should always follow those 4 steps. First, you need to define the ISR lesion using imaging. Also identify the risk factors and address them. In this gentleman, he is still an active smoker. He's non-diabetic, but we told him to quit smoking. We also want to address the mechanical issues. So we're going to review the intravascular imaging to see if there's any stent fracture or underexpansion predisposing this patient for ISR. Although, like I mentioned, because the stent was implanted 13 years ago, it's somewhat expected that the stent will fail at this point, even if there was no mechanical issues. And finally, we're going to treat the underlying lesion with the drug-eluting stent. Hung, you want to add anything?
No, I think what's interesting is that, as Robert mentioned, there's two great reviews back in the past 12 months, one from Jack, one from your intervention. As you can, next slide, as you can see, there is a couple of algorithms out there. I think the European one is, I think, very straightforward. It's based on the imaging that the information that you get from imaging. Maybe next slide. I don't know if Robert wanted to comment on the last slide.
So this is a proposed algorithm for in-stent restenosis. They can review offline, but the idea here is that you only get maybe one or at most two chances to treat it. If you have more than 3 layers of stents, the rates of ISR increase exponentially. They're greater than 20% per year with 3 layers of stents, and bypass should be considered at that point. In this gentleman, he only has 1 layer of bare metal stent. It's a 3.5 millimeters, so it's a large vessel. So we're going to take the middle path in this algorithm with 1 stent ISR, and we're going to use imaging and do proper lesion and vessel preparation before implanting a 2nd layer of DES. Our approach here is if it's a late ISR greater than 1 year, we tend to reimplant a stent according to the underlying lumen, but smaller vessels or earlier ISR could also be treated in Canada with drug-eluting balloons.
Yep. So the only drug-eluting balloon that we have available currently is the Pentara Lux. It's a paclitaxel base balloon. As you can tell, can we replay the RCA image? Peux-tu le rejouer, Jen? L'image de la droite. So you can see that the DES that was put in the distal RCA and into the PDA is larger in lumen, and this was treated with DES. So this is a patient that, despite risk factors as described by Robert, we think that the DES in this prox to mid segment of the RCA will be something that will help the patient. I mean, right before entering consulting at our ER, the patient had even nocturnal symptoms. He was awakened by angina. So this is clinically very, I think, relevant for us to do. As we discussed on multiple occasions during the slide sets, we were ready to perform imaging. So the imaging of choice, at least in my mind, for ISR patients is the OCT, while IVUS will get you assessment of the lumen area. I don't know if everybody can see the OCT images, but I think from my perspective, this is a personal comment, there are pluses and minuses, advantages and disadvantages between IVUS versus OCT. However, I strongly believe that the OCT is more intuitive for interventional cardiologists, and with ISR, you get to really be able to see the lumen and the surrounding areas. And the penetrance, even though IVUS has more advantage, you actually see more of the calcium. You can't, for example, measure depth of calcium with IVUS. You can actually see the cone dome, but you don't see the depth. The length you can assess, the diameter stenosis also, obviously, as well as the lumen area. But I think the advantage of having a clear idea of what kind of plaque modification we have to go for, I think this is really the key aspect with the logic of using OCT. So with no further ado, we'll show you the image. As you can see, there's that small aneurysm from the angio that you saw, and this is at the 10 millimeter mark.
We don't have co-registration with OCT and our angio suite, but this is exactly the aneurysm that you see right in the mid RCA as it plunges vertically on the
So we'll start playing from there and let you assess with us. So as you can see, this is the rule of fives. So more than 50%, more than 5 millimeters in length and 5 millimeters in terms of depth. We absolutely have it right even before the stent. The stent is around the 17 to 18 millimeter mark. You could see that within the stented area, there's not much calcium, but there's clearly intimal hyperplasia. We're coming out of the stent now, and again, you're seeing a lot of calcium. There's a fair amount of calcium in the medial aspect of the artery. I think it was 2 o'clock and 7 o'clock. And again, as we're nearing the ostium of the RCA, it's fibrocalcific, more fibrotic, closer to the ostium, but towards the 40-minute mark, 40 millimeter mark, you can also clearly see around there, there's calcium, I think. Or a bit before, maybe. Yeah, there's calcium there as well, and there. So at 35, there's a lot of calcium in the media. So initially, when we had looked at this, we were thinking, obviously, debulking and then delivering materials, but due to the data, the information that we gained from this OCT run, I think it's clearly not necessary to proceed with atherectomy. And I think what we will do is POBA, plain old balloon angioplasty, and then move on until proven otherwise to IVL to really crack the calcium. And
we also plan to use cutting balloons inside the stent. Just because of the severe intimal hyperplasia. So cutting balloons allow us to open up the scar tissue, improve the delivery, and also improve the expansion afterwards, and should be used in cases of intimal hyperplasia. So this is another area where the OCT helps us choose our balloon.
20, maybe? The 20 book.
Yeah, the 20 millimeter.
Yeah. So this is in-stent also more towards the distal aspect. So you saw proximally and maybe a bit before the 18-minute. So the lumen is actually really narrowed.
Yeah, and it looks homogeneous. Yep. So this is the hallmarks of intimal hyperplasia, but there is a bit of neoatherosclerosis at the outflow of the stent.
So you see
as well.
You see the stent, so we're clearly still in the stent. So with that, we're going to proceed now with.
So we have a JR4 guide. We have a run-through wire, I believe, and we will start first with the cutting balloon. We took a Wolverine 3.0 by 12 millimeter balloon, and if we don't have enough support, we're going to have a guide. We have a Guidezilla ready on the table that we will proceed to use to increase our support.
As you're seeing me engage the RCA. Est-ce que tu peux mettre l'image plus grosse, s'il te plaît? Oui. You're seeing me engage and the pressure changes.
Pressure damping on the
damping. So we're clearly inside the lesion. Hopefully we'll get enough support to deliver this 3.0 cutting balloon. If not, we'll proceed with some inchworming using a 6 French guide extender. We'll proceed inside the stent to really help us expand it. Measurements were performed, and we didn't show you, but we were closer to 3.3. This is the instented. I think it actually delivered very well.
Laurel, can we put the reference? Thank you. Okay, on floor.
Okay, I think we're good. It's instant.
Instant. You want to go here? Yep.
Yeah.
So we're going with the cutting balloon instant. I'm at 8.
And with
so this is around 3.15 millimeters. We actually measured inside the stent. The stent is a 3.5. It looks like it was expanded around 3.4 millimeters.
Yep.
Off.
So initially we found the initial reports from 2009. It was a BMS 3.5 by
on 10.
3.5 by 14, which was not post-dilated.
12. This is the maximum rated pressure, 3.28 millimeters.
Off.
Looks like a good expansion.
Yep. We're going to control the ACT. While we're controlling the ACT, there's debate, I guess, from the audience of what we could proceed with as the next step in terms of the angioplasty. I think here at this juncture, since we have the information from the OCT, I think going in with an NC in and around the stent will not be favorable in my mind. We have to get stent expansion. So since we measured everything initially. Here. Go. So it's expanded more. So the plan is to go ahead and proceed with IVL to really crack the calcium. And with that, we'll proceed with the shockwave balloon.
Yeah.
Est-ce qu'on a le shockwave 3.0? Ah, okay. So
you can
right.
see also distally, there's a severe lesion now in the mid to distal RCA that was not there on the reference. I think this could potentially be spasm.
Yep.
Could also
Right.
be a dissection, but would be unlikely. I think it looks more like spasm, but we'll see. We can actually give some nitro.
Yeah, wire bias.
See how it, some wire bias would be.
If not,
although I had a wire before.
Yeah.
But we'll see how it responds to nitro. It looks like spasm.
Nitro 1 doesn't respond, and we'll go assess it. Of course, right now I won't pull the.
Second, I'm waiting for the pressure.
Yeah. Wait. C'est
Okay.
un petit peu encore la nitro, je sais pas ça. Okay. Okay, pressure has dropped. Okay. I'm just gonna. Okay, vas-y. Actually, it looks like a lesion, unless.
That we did not see. So we did not see that lesion on OCT. We actually went that far.
Really? Well, I don't think we.
And it's possible that it was caused by the wire. You can see how the PDA now is completely vasodilated. It looks twice as big as initially. There's that lesion.
Yeah.
So we're going to have to cover the distal.
We'll cover the distal as well.
Do you want to use non-compliant balloon first?
Yeah.
Yeah.
Okay. Yeah. Est-ce qu'on peut avoir un 3.0, un NC 3.0? We'll go with a non-compliant for the distal. The shockwave. Oh, okay.
20.
20. So I'm being informed that our lab is so active that right now
le plus long 3.0 non
the shockwave device is actually being used in our hybrid room because they're actually doing a peripheral access. So for the time being, what we'll do is assess with what's going on with the distal lesion. We had no issues.
No,
it's not.
So it looks like spasm.
Okay, go. Okay.
So
actually pretty good. The other issue is no matter. So since that's resolved, what we could do is if I see that in the coming minutes we don't have access to the shockwave, what we could attempt to do is get an OPN 3.0 to try to crack, and then once we use the OPN, we could move towards another OCT assessment. Because at the end of the day, what we really want is to be able to cause fracture that ideally are visible. There is data out there when you talk to KOLs such as Ziad Ali. He has mentioned there are studies that show that even though we might not see necessarily on OCT some fractures, there might be some micro fractures that you could have as well using IVL. But with OPN, I mean, ultimately what you want is fracture. So if the IVL is not available, then as a fallback plan, OPN is the next one. I would not necessarily favor a standard NC as the pressure that you can gain versus a double lumen balloon such as the OPN might not be able to obtain the crack that we want. The deeper calcium that you saw in OCT will not allow us, will not be adequately treated with cutting balloons as meant by different algorithms. That's not something that we would favor. So while we're getting ready, I think the patient remains stable, well sedated. And so this as most of you know, watching the audience, this case, c'est normal, monsieur. Est-ce qu'on peut lui donner un 50 de fentanyl?
Puis un de Versed.
So, as you know, ISR cases are not the most technically challenging, but The issue is that when something is not technically challenging for interventionists, we sometimes tend to go quick. I think in a case like this, with a patient with a lot of risk factors for ISR, with the possibility to implant a DES, the ideal mechanism would be to the ideal way strategy is to really understand what we're tackling instead of having a high-end complex PCI, so that we don't have to come back and the patient does not need to have a recath for the same symptoms.
Yeah, we want this drug-eluting stent to last them another 13, 40 years at least, like the first one. But it is more challenging now because of the lumen loss. So we're getting the Shockwave 3012 balloon ready. And we're going to see how the lesion responds to the Shockwave.
We'll see. Hopefully, we'll get some fractures.
Hopefully, we can go in the mid portion.
Yep. Close to the aneurysm.
Yeah. I'm overlapping a bit the aneurysm.
What? Oh, there's no more? Oh, pas 3.5, 3.0, il y en a pas.
Okay, we'll take 2.5.
Okay, so
2.512.
Unfortunately, our we had a 3.0. It was used right. We had a 3.0 before, but another room. Wait, so we will oversize a bit the 2.5.
Yeah, we'll go 8 atmospheres, right?
Yeah,
6
8 to 10. I usually, so this is controversial. It's certainly off-label. What they usually recommend is around 6 atmosphere, a sort of a some will say 1-to-1, others will say a upsize by 0.5. Unfortunately, when we had prepped the case, we had the 3.0, but in the meantime, we have 4 labs running at the same time. The 3.0 is no longer available. So we'll make do with what we can, and we'll see what we can do with the 2.5 and assess by imaging. So if the 2.5 does not do what we want, we'll head for an OPN. Always troubleshoot.
So there's a question for you guys.
Yes.
And it goes, what are the most promising strategies for preventing or reducing the incidence of restenosis after coronary intervention?
So I think, especially in lesions that are not type A lesions, we're talking about calcified lesions or bifurcations or long lesions. We recommend using the intravascular imaging, either IVUS or OCT, as per Renovate PCI study, which has shown superior results with imaging. Also modification. So this is for the technical or the procedural aspects of the risk factor.
I think, je pense qu'on est correct là. On est correct là.
Now, from a clinical perspective, we have to treat the risk factors of the patient, and diabetes needs to be treated. That's important. Also, smoking cessation and basically treating all the coronary artery disease risk factors is of the essence. Finally, there's data on the duration of antiplatelets, and ideally, if the patient already had in-stent restenosis, there will be benefits of prolonging that duration beyond 12 years, especially in acute coronary syndrome situations, because this could reduce the incidence.
So you're seeing me work the lesion. So we have 80 runs. And what we're doing right now is we're upsizing to 10 atmospheres. So obviously this is sort of not what is ideally recommended, but ça se peut que vous ayez des douleurs. I think with the audience that we have, the question pertains more to the interventional aspect. And as Robert mentioned, the landmark study that recently has been published, the Renovate Complex PCI, if we follow the definition of their complex PCI, I think for us to get into this same scenario, a scenario of in-stent restenosis, we really have to be careful and cognizant of the data and modify our strategy according to the data that we're obtaining from imaging to then decide a strategy. And as we initially, we're at 12 atmospheres.
So this is only a 2.5 balloon. We know the vessel measures at least 3.25 to 3.5 millimeters. It's severely calcified at those regions, so we feel comfortable going
Oui,
higher.
fentanyl 50. Il y a des douleurs, c'est normal. On travaille dans l'artère.
Patient having chest pain at the moment because of the shock wave and the prolonged inflation. So this is expected in this type of therapy.
This is actually a good sign. We're
Means we're
physiology
treating-
and clinic is on the side of us intervening. We're 12 atmosphere. So we've all usually we talk about doing IVL. So doing IVL will c'est fini. I think we can do
maybe a bit more proximal.
okay.
Okay, so
Loose.
12 atmospheres. This is the 6th treatment. So we already gave almost 60 shockwave treatments out of the 80 that is allowed per balloon.
Yep.
So we delivered 6 therapies.
We'll keep 2 just in case we'll
keep 2 in case we have trouble delivering the equipment or we don't get.
So it's really optimizing, and then I think with OCT, the MLD max sort of approach, and it was recently discussed in the last few months by Kevin Croce from Brigham and Women's. We actually were there at the same time, and it really shows you that most of the time, a lot of people tend to think about using imaging and OCT as a marker to check what's happening afterwards, but also what Kevin and the Brigham group found was that a lot of the advantage of having sort of that algorithmic approach to imaging.
We gave 2cc nitro as the nitro.
Okay. So we see dissection, so that means we did manage to crack something, so that's good.
There is a dissection proximal to the aneurysm.
And
that's
distal.
where we went with the shockwave, and also at the stent
Okay,
area where we went with the cutting balloon and the shockwave.
We'll do OCT now just to assess what we got.
Yeah.
So as I was saying, the advantage of having a algorithmic approach to imaging and guiding your PCI is that most of the time, a lot of people presume that it actually changes the pulse dilation, but it changes what we do before the stenting and not just what we assess after the stenting. And this was actually the case with this patient. We initially had planned for rotational atherectomy. We had planned for a more aggressive way of treating it, but seeing that most of the plaque was fibrotic and there was some calcium, but not so much intraluminal calcium, but more medial calcium, we were comfortable heading in to this case, performing more IVL, IVL to allow us to counter some of the technical aspects related to okay.
So we're right at the aneurysm. You can see the angio. We're going to go in the live view.
Hopefully you can see this,
yeah,
right?
We're doing, the catheter is winking at us, so that's a good sign.
Great.
All right, we're going to change the injection parameters.
So we use 4/18 and 400 PSI.
It's going to make sure we get good clearance, so that looks good.
Okay.
And enable pullback.
Auto calibrate.
Yep. First.
And you'll see this live.
Enable pullback.
Okay.
Cine.
Yep.
Perfect.
Excellent. So we'll look at all this together.
It's the dye. The dye came out because the valve was a bit open. So you can see here the dissection. I think we passed very quickly.
Attention, attention. Il y a quelque chose qui avait accroché.
Okay. You can see the dissection. We're going to measure the lumen here, but the tightest lesion, we were at 2
So we have some
square.
dissection and
there's some fractures here.
Some fractures as well. So this is good news. So we were a bit more aggressive as recommended by than what is recommended by the for IVL use. There's some fractures that you see, so that's good, and dissection as well. And this, again, some dissections here.
So that's expected with the cutting balloon that we use, and also the shock wave.
This is the shock wave that we used with a 2. And remember, this is a vessel that was initially, well, I think we have some fractures as well in the distal end.
I think our objective here with stenting will be to stent from the aneurysm all the way to the almost to the ostium, actually.
Yep. I think we have
so it's almost like a it's almost like a 40 millimeter.
Yeah, 48. Est-ce que tu peux mesurer Mike, de l'anévrisme de là?
Do the lumen contour?
Oh, no, it's just the length. Yeah.
This is a 3.0. You can see the 3.0
okay.
vessel.
Then we're going to measure the length.
Yeah.
From
all the
there,
way to the ostium.
Maybe to the ostium. At least we cover
42.
42. So we're going to have to do it with
probably
two stents.
Okay.
Versus we could get the 48, the synergy 48, and then it covers a bit further down. Yeah. Okay. So we'll get a 3048.
So we'll use the DS synergy. It's a 48 millimeter stent that we aim to deliver all the way in the mid to distal portion
to
the ostium.
Okay.
This will minimize the chances of us missing the stent overlap, and will minimize also the risk of restenosis. It is a very long stent, which will increase the risk of restenosis, but
however,
in this patient, there's disease everywhere.
Yeah, there's
so
disease. There's and also what my strategy to try to use one stent is to have less issues with overlap.
Exactly.
Just to make the patient more comfortable. So having a longer stent might be obviously a risk factor, but having 2 long stents to treat
275/48.
Yeah, 275.
We don't have 3.
Okay. Well, we can
so again that later. So we have to play with the equipment that we have on board.
I'm sure everybody in the audience is fully aware that there are always little mishaps here and there in terms of material, especially post-COVID.
But so Dr. Lee, he's the MacGyver of intervention. He's going to figure out the way to figure things.
And we have imaging. And again, with this platform, the 275 synergy, we can clearly bring it all the way up to 375. As mentioned by Robert initially, when we started the case, obviously a lot of you have seen that there is some calcium, and it's a very horizontally situated prox segment of this RCA. So if you have any issues delivering this, I will clearly...
We'll have the Guidezilla on board,
exactly.
so we'll have different approaches to deliver this if it doesn't work. But so far, surprisingly, we did not have much issues with the JR.
The way I do things is I try to have an anti-Murphy's law. Est-ce qu'on peut mettre un grand écran, s'il vous plaît?
Yeah. Switch the OCT and the live angio, please.
So, try to plan.
Okay.
So, try to plan ahead.
There's a bit of resistance there, but not much effort. Dr. Lee made this look effortless.
It was a big effort. No, I'm just kidding.
This is years of experience.
Yeah, I'm getting old. 15, 16 years now.
15 years.
So it's actually a privilege to work with my younger colleague. Okay, everyone. I think we're covering everything.
Laurel?
Yep. Might want to pull back a bit. Yeah. Okay.
On?
Yep.
On. I'm going
275.
We're going to take this to 18 at least, because we know it's a 325 vessel. So the stent outer diameter now is at 3.22 millimeters.
Yep. Ça se peut qu'il y ait des douleurs, c'est off.
Off? So we see you covered the ostium. There is a good blood return in the aorta. We're removing. This is a very long balloon, so we have to take our time when removing it.
This is it. We're at 18. So obviously.
Non-compliant balloon 3.5, 3.5 quelque chose, 20.
Une petite puff pendant qu'on a encore le ballon en place. As you see, it's already... Garde celle-là. Mais garde-le, c'est plus important.
Fluoro safe.
Yep, fluoro save. So this, we pull back the wire. Of course, now that the prox to osteal segment has been stented, we really have to be careful regarding the. On va vous donner quelque chose pour le confort. Oui, 3512. Est-ce qu'on peut donner un fentanyl
25.
25?
Désature un peu.
Oui. OK, ben on va le laisser. Correct. OK. OK.
Combien sur 10 la douleur?
OK. So we're just going to optimize this
Combien sur 10 la douleur?
with a 3.5 by 12 and then
Ça va
head
diminuer.
to finish with
On a
the
toujours fini.
imaging.
The patient has 7, 8 out of 10 chest pain, but we put such a long stent.
Yep.
And we'll occlude the vessel multiple times, so expected. We're just going to pose that and we're just going to make sure there's no complications.
Yep. So he's hemodynamically stable. There's no evidence of perfing. I think the initial reflex when the patient has pain is to go shoot more contrast and go see. But the clinical cues right now, despite the chest pain, does not point to a major complication. So we'll move along with a post dilation before completing this with imaging. Il y aller peut-être plus de façon pas trop. Attends. OK. C'est juste nominal. OK. Okay.
12.
We're at 12 atmosphere with a 3.5.
So we're nominal, so we're at 3.5. Pull back.
Ouais. Okay. Vas-y.
On 12.
I'm going to give nitro after this. Pressure is
Off.
clearly allowing us. We have plenty of room. As I'm pulling back, I'm opening my O-ring.
This is where the previous stent was.
Okay.
18, 18.
Off. On.
This is where the previous BMS was. 18. Off.
Okay. Okay. On.
18, 20. Off. A bit more back.
Yeah.
That's it. 20.
Garde celle-là. Maybe I think we might have a bit, a little left.
To cover?
Yeah.
Here, yeah.
Yeah.
To pose that way.
Okay. All right.
Maybe a bit more.
Yeah, exactly.
I don't think we nailed the ostium. Yeah, okay, on
Very
here, this looks like it keeps sliding forward a bit, so
Again,
maybe we
that's
could do it in the aorta.
some of the advantages of having. Okay.
Yeah, it keeps
Realign.
sliding forward.
Okay.
They're doing some backward
traction. Okay, go there. There you go.
Oh, okay, this looks good. Okay, off 20. Trying to make sure that we pose that at everything. So we know at 3.5 we're 1-to-1 with the vessel.
Oh, I'm just making sure the ostium is okay. Okay.
I'm gonna do here something we call the TAN. So we're gonna toss some bloods, do the ACT, and give 1 cc of nitro.
Yeah.
The TAN.
Robert has all of these
I have acronyms.
nifty acronyms, so always love working with him. So it's always awesome.
ACT and
ACT,
nitro.
yeah, nitro. Okay. ACT.
2 cc of nitro.
Okay.
Now it's possible that the distal segment now is going to look a bit undersized.
More appropriately sized compared to the prox segment.
Okay.
So
But this is what we, if that's
Exactly,
the
that's
case, that's
what-
what we call the new couch sign. So we put
Exactly.
the new couch in the Proximal RCA,
okay, go.
and everything looks pale in comparison. I think that looks fantastic.
I think we're pretty happy with the results.
Yeah. Should do the OCT.
Yep, we will complete this procedure with OCT. I don't know if in the meantime there's any questions from the audience.
Yeah, there is.
Yes,
it says,
please go ahead.
How do the location and severity of stent fractures or dissections impact the risk of restenosis?
I think having dissections has not been associated with restenosis per se. I think unless I'm misunderstanding the question, but from a if it's a morphologically oriented question in terms of having a site-specific reason why there's restenosis, obviously what is well described is osteal lesions that are more prone because of the lamina. RCA is not the same at the ostium compared to the rest of the vessel. However, having a dissection or a calcified lesion, whether it's in the prox, mid, or distal segment, for example, of this vessel, I don't think that in and of itself.
I haven't seen anything on the topic either. However, stent fractures are a known risk factor, especially for early ISR. And the way to prevent stent fractures is to not dilate the post-dilate the stents beyond the recommended limit. So there are handy charts according to the manufacturer of the stent and the brand that we should follow. So the DS synergy, I believe, can only be post-dilated all the way to 375, but we cannot take this stent, for example, to 40. Otherwise, we increase the risk of
having
stent
some
fracture.
issues, and I don't want to cause any manipulation issues with the prox. Okay, now I think we've managed to.
Yeah,
okay, there was some interplay at some point.
Okay, view.
So having a stent fracture, of course, is a risk factor, but having dissections or other
auto-calibrate
issues, it's not been well associated with.
Okay, enable fullback.
Yep. And we'll see together the results.
Cine.
So all of the.
So we image distal to the stent all the way to the osteal RCA. So we can also use the angiogram to see if there's any perforations. And we'll also do a final angio if everything looks good without the guide wire to rule out perforations.
For sure.
So normally,
distal.
if everything looks good, we do 2 orthogonal views. If we don't use imaging, but if we use OCT, because we already have an angio to minimize that, we can only do 1. And the reason we do 1 is to rule out perforation, because all the other complications can be ruled out on OCT if it was done properly. I mean, so already here we can see the expansion ratio is like.
Can we switch the imaging?
1,060, not at 1,000, 116%, which looks perfect. So we're aiming for above 85 expansion ratio. That's what's recommended for OCT. It really depends on the reference of the vessel that we put.
But everything seems to be. On assessment, you know, when you look at it, the expansion.
Mike, can you put the yellow?
Is very nice.
The red that's in the guides. The arrow to the left.
You mentioned the MSA that we see.
No, the other arrow.
Yep.
Release this arrow. Move it. Yeah, inside.
Okay, ça se passe très bien. On a presque fini. On fait juste faire des images, puis on a terminé. Ok, vous avez très bien fait ça. Ouais.
You can also see, like,
vous avez des douleurs.
At around 5 millimeters, the area is 5.11 millimeters square. We're pre-procedure at 2 millimeters square, so we almost triple that area.
Vous faites très bien ça.
We can just play the OCT, but the stent looks well expanded and well opposed. There's no dissections, and the expansion ratio is satisfactory.
Yep.
So I believe we are done.
We're aiming for an MSA of really above 5.5, which is the case here. There's no issues distally in terms of the dissection, and proximally, I was talking to the patient, so I apologize for that. But proximally, I don't think there's any major issue. You can even see on the longitudinal axis of the OCT that the proximal dissection again was done by which was caused by a 2.5 shockwave, is well covered by the stent, and there's really no.
No, and we saw the
issues here.
previous. I think we were able to see some struts of the previous stent.
So what I'll do, since as you all know, if we do an osteo lesion and we don't leave a guide wire, sometimes it gives
the guide can pop out,
and then we lose another half hour just trying to get that last final image, which in this case we won't, because I'm keeping it in the stented segment in the floppy part of the wire. Oh,
there it is.
There it is. It's flipped out. So this is all the.
I think that looks good.
I think we're good. All right.
Chine.
I think we're very happy. There doesn't seem to be any.
There's no perforation. The stent is well expanded. It's well posed on
I think we're
OCT.
very
There's
happy.
no distal edge dissection.
Can we show a pre for this case, Jennifer? Est-ce que tu peux nous montrer le premier, s'il vous plaît? I don't know if so this is the post OCT guided. So this is the pre when we wired it. Now show the post. So what we initially thought was the aneurysm was probably a healthy segment, the only healthy segment in that mid portion, and we managed to upsize it to 3.5. As you all know, with the OCT, sometimes you can even upsize to a 0.25 size in terms of ballooning versus IVUS when we're talking about EEL to EEL. So that's what we did with a 3.5 to post dilate that 275 synergy. So there's no overlap, no dissections with anything. So I think we're done for the day.
There's one more
Any
question.
Yes, please.
What are the most effective pharmacological agents or drug-eluting technologies for reducing the risk of restenosis after coronary interventions?
I mean, I think right now there's no added pharmacological agent that I am aware of to prevent restenosis of a freshly implanted DES. If the question is about a restenosis of a DES or a BMS that is refractory after image-guided PCI, that you still have a recurrence of in-stent restenosis, there's protocol. I think it was published in Circ in 2005. There's a 3-day protocol where you can have oral sirolimus that has been shown in an observational series to have better outcomes for in-stent restenosis. But again, that was published in an era where it's not the latest
I think
DES.
In this patient that's not on oral anticoagulation and that has no risk factors for bleeding, we could consider extending the duration of the antiplatelet therapy beyond 1 year with Plavix or Prasugrel. Not ticagrelor because he had bradycardia and he had symptoms to side effects of ticagrelor previously.
So for the audience, I don't know if people have changed their practice. Obviously, the new trend is to look towards SAPT, excluding aspirin, of course. And with the Sydney 2 data out there, I think clopidogrel for this gentleman, it's almost in a funny way. I'm an older physician than I would hope to be, but this is almost a Capri-like patient in a way. But with the recent Sydney 2 trial, the data, I mean, meta-analysis, then you could easily pursue this SAPT with clopidogrel beyond the 3 months in this stent as well if there's any issues. But if he tolerates it, I can clearly go for long-term for this patient with many risk factors, cardiovascular and all. Any other questions? If not, we'll get this patient off the table and back to his room so he's more comfortable. Our beds tend to be not that great.
Hard as
Okay.
intimal calcium.
Well, we'd like to thank everyone and thank the whole team, and thank you for taking the time. We appreciate this and also the opportunity. Thank you very much.